Hello, class. Welcome to Flourish Nursing Academy. This is Tutor Godwin. I'll be discussing glaucoma. The term glaucoma is a term used to refer to a group of ocular conditions characterized by optic nerve damage. Glaucoma occurs as a result of increased intraocular pressure, IOP, caused by a malformation or malfunction of the eye's drainage system. Normal IOP is 19 to 21 inches of mercury. The increased pressure causes compression of the retina and the optic nerve, and causes progressive permanent loss of eyesight if left untreated. Glaucoma is a group of disorders characterized by an abnormally high intraocular pressure, optic nerve dystrophy, and peripheral field loss. Glaucoma is a symptomatic condition of the eye where the intraocular pressure is higher than normal. Normal IOP is 16 to 23 millimeters of mercury. Incidence rate: globally 6 to 67 million, more common in people older than 40 years. Causes: 1. Increased intraocular pressure, more than 24 millimeters of mercury. 2. Optic nerve dystrophy. Risk factors: genetic factors, family history, aging, above 40, eye trauma, hypertension, severe myopia, ocular surgery, diabetes mellitus, migraine headache, emotional excitement, caffeine consumption, increases IOP, ethnicity, more common in black people compared to white people. Prolonged use of corticosteroid. Pathophysiology: glaucoma is a group of eye conditions characterized by damage to the optic nerve, often due to increased intraocular pressure. IOP. Key mechanisms: 1. Increased IOP, elevated pressure within the eye, often due to impaired aqueous humor drainage. 2. Optic nerve damage, compression and damage to optic nerve fibers, leading to vision loss. Types 1. Open-angle glaucoma, gradual increase in IOP due to impaired drainage. 2. Angle closure glaucoma, sudden increase in IOP due to blocked drainage. Consequences: 1. Vision loss. Permanent damage to the optic nerve can lead to irreversible vision loss. 2. Blindness. Untreated glaucoma can progress to blindness. Classification of glaucoma: A. Congenital glaucoma. 1. True congenital. 2. Infantile. 3. Juvenile. B. Acquired glaucoma. 1. Primary glaucoma. 2. Secondary glaucoma. Congenital glaucoma. A rare disease, occurs when a congenital defect in the angle of the anterior chamber obstructs the outflow of aqueous humor. If left untreated, causes damage to optic nerve damage and blindness. 1. True congenital glaucoma occurs when IOP increases during the intrauterine period. A child is born with ocular enlargement. Occurs in 40% of cases. 2. Infantile glaucoma. Occurs during the third birthday, occurring in about 10% of cases. 3. Juvenile glaucoma occurs during 3 to 16 years of life. Occurs in about 10% of cases. Clinical features of congenital glaucoma: lacrimation, photophobia, corneal edema, raised IOP, eyes become myopic, corneal diameter more than 13 millimeters of mercury. Acquired glaucoma: 1. Primary glaucoma. A. Primary open-angle glaucoma. B. Primary angle closure glaucoma. C. Chronic angle closure glaucoma. 2. Secondary glaucoma. A. Lens-induced glaucoma. B. Glaucoma due to uveitis. C. Neurovascular glaucoma. D. Glaucoma associated with an intraocular tumor. E. Steroid-induced glaucoma. Primary glaucoma. Primary glaucoma is a progressive condition and is the most common cause of irreversible blindness worldwide. A. Primary open-angle glaucoma. also called open-angle glaucoma, or chronic simple glaucoma, or simple complex glaucoma. Results from the overproduction of aqueous humor through the trabecular meshwork result in increased IOP and damage to the optic nerve, resulting in loss of vision. The clinical features of primary open-angle glaucoma include mild ache in the eyes, headache, increased IOP more than 24 millimeters of mercury, loss of peripheral vision, reduced visual acuity at night, corneal edema, visual field deficit. B. Primary angle closure glaucoma. It is also called primary closed-angle glaucoma, narrow-angle glaucoma, pupil block glaucoma, and acute congestive glaucoma. Onset: rapid ophthalmic emergency. Unless treated promptly, the causes of blindness in 3 or 5 days. This is due to the abnormality of the structure in front of the eyes. This results from the obstruction to the outflow of aqueous humor. Clinical features of primary angle closure glaucoma: pain and redness in the eyes, increased IOP, blurred vision, headache, nausea, vomiting, edematous cornea, decreased visual acuity, moderate pupillary dilation. C. Chronic angle closure glaucoma. Chronic angle closure. Glaucoma may develop as the sequelae to an attack of acute angle closure glaucoma. Clinical features include 1. Increased intraocular pressure. 2. Visual field defect. 3. Decreased visual. 2. Secondary glaucoma. Secondary glaucoma occurs as a result of, or diseases within the eyes, such as uveitis, inflammation, trauma, intraocular hemorrhage, previous surgeries, diabetes, and steroid medication, etc. The major types include Types 1. Lens-induced glaucoma. 2. Glaucoma due to uveitis. 3. Neurovascular glaucoma. 4. Glaucoma associated with intraocular tumor. 5. Steroid-induced glaucoma. 1. Lens-induced glaucoma. It occurs due to trabecular blockage. It occurs due to the clogging of trabeculae by inflammatory material. 2. Glaucoma due to uveitis. IOP is raised due to clogging by inflammatory material and associated trabeculitis. 3. Neurovascular glaucoma. Uncommon type of glaucoma. Difficult to treat, caused by proliferative diabetic retinopathy. Individuals with poor blood flow to the eyes are highly at risk for this condition. 4. Glaucoma associated with intraocular tumor. Intraocular tumors, such as retinoblastoma and malignant melanoma, may raise IOP. 5. Steroid-induced glaucoma. Developed due to sensitivity to steroids. A sudden rise in IOP may occur. This can be prevented by judicious use of steroids. 6. Pigmentary glaucoma. Rare condition. This is caused by pigment cells sloughing off from the back of the iris and floating around the aqueous humor. Diagnostic measures. 1. History collection. 2. Patient ocular and medical history. 3. Tonometry to measure IOP. 4. Ophthalmoscopy to show the cupping of the optic disc. 5. Gonioscopy to determine the angle of the eye's anterior chamber. 6. Perimetry or visual field test to detect loss of peripheral vision. 7. Slit lamp examination. 8. Fundus photography to monitor the disc for changes. 9. Pachymetry or nerve fiber analysis to assess the thickness of nerve fiber layer. Management. The goal of management measures includes to reduce IOP to prevent damage to the optic nerve. Management measures mainly include medical management, surgical management, nursing management, medical management, beta-adrenergic blockers, decrease aqueous humor production, e.g. timolol, beta-xolol, cholinergic miotics, Reduces IOP by facilitating the outflow of aqueous humor, e.g., pilocarpine, carbachol. Carbonic anhydrase inhibitor decreases the formation and secretion of aqueous humor. Prostaglandin analogs reduce IOP by increasing uveoscleral flow. Osmotic agents, IV mannitol, 20% or oral glycerin 50%, is used to reduce IOP by creating an osmotic pressure between blood and intraocular fluid. Surgical management. Argon laser trabeculoplasty, used to treat open-angle glaucoma. Thermal argon laser burns are applied to the inner surface of the trabecular meshwork to open intratrabecular spaces, thus reducing outflow of aqueous humor and decreasing IOP. Laser iridotomy. In this surgical procedure, an opening is made by the laser beam in order to eliminate pupillary block, relieve the pressure, preserve the vision by promoting the outflow of the aqueous humor. Cyclocryotherapy. Application of a freezing probe to the sclera over the ciliary body that destroys some of the ciliary processes results in the reduction of the amount of aqueous humor. Cyclodialysis. Through a small incision in the sclera, a spatula-type instrument is passed into the anterior chamber, creating an opening in the angle. Filtering procedure. For chronic glaucoma, a filtering procedure is used to create an opening or fistula in the trabecular meshwork to drain aqueous humor. This allows the aqueous humor to flow and exit different route. Trabeculotomy. In this procedure, a partial thickness incision is made in the sclera. A section of the sclera is removed to produce an opening for the outflow of aqueous humor. Drainage implants and shunts, used to shunt the aqueous humor in the conjunctival space. Implants and shunts are the open tubes implanted in the anterior chamber through a sclerotomy. Nursing management, assessment, history collection, positive family history. Risk factors such as tumors of the eyes, intraocular hemorrhage, inflammatory intraocular uveitis, cow eye contusion from trauma. General physical examination. Assess for sudden severe pain in eyes, halo light, blurred vision, etc. Check for diagnostic measures. Assess the patient's understanding and emotional response to the condition. Nursing diagnosis. Acute pain related to increased IOP. Self-care deficit related to loss of vision. Fear and anxiety related to pain and potential loss of vision. Risk for injury. Nursing intervention. Assess the IOP. Elevate the head end of the bed at a 30-degree angle. Patient should be placed on the unoperated side. Instruct the patient not to touch the eyes. Encourage the patient to wear an eye shield to prevent infection. Administer medications as prescribed. Complications. Complete loss of vision. Choroidal detachment. Retinal detachment. Chronic hypotony. Anterior segment. Necrosis. Research studies. Safety and efficiency of biomatoprost sustained release in patients with open-angle glaucoma or ocular hypertension. Conclusion. Glaucoma is a condition that causes damage to the eye's optic nerve and gets worse over time. Without treatment, the glaucoma can cause permanent blindness within a few years. So the treatment should be given at the right time to prevent complications.